You didn't think I'd start with this slide, did you? Well, I'm going to do a little bit of bragging. I'm a social media geek, even though I have a fair amount of gray hair. I'm very active on Twitter. I'm the only person I know who consistently posts video images on Twitter. And my nose is a little stuffy, so forgive me. The colds are back, unfortunately. And I do have a very active YouTube channel as well, where there are a fair number of videos on gastrointestinal and bone and soft tissue, but believe me, there are some on head and neck pathology as well. So my job here, or this is what Dr. Nose asked me to do, is to talk about inflammatory lesions of the head and neck. I'm going to focus on IgG4 related disease and then perhaps move a little away, particularly talk about the mimics of IgG4 related disease. And I really do feel that I think it is more important to realize what is not IgG4 related disease than what is IgG4 related disease. Some of you who may know me would be familiar that I spent almost 22 years at Mass General Hospital. I moved across town, which is a slightly higher, closer to the medical school. I am also the editor-in-chief of the Journal of Clinical Pathology. So this is a journal that's been around from 1947. It is one of the oldest journals, and most of it is surgical pathology, although we do publish some clinical pathology articles as well. So if you have a paper ready to go, please send it across to me. There's my email. So a little more than 10 years ago, this is very early, relatively early in my career, I put together this issue of the Seminars in Diagnostic Pathology, and we talked about what is IgG4 related disease. 12 years on, perhaps, hopefully, if everyone makes their contribution in time, it'll be 12 years on. We have another issue coming in. We are not this time, but there are some changes happening. One is we have a new editor, Justin Bishop, and what I'm going to focus in on, and I have experts and skeptics of the disease who are going to focus on mimics of IgG4 related disease, because I promise you the next case that hits your desk and you think is IgG4 related disease, it's probably not IgG4 related disease, and that is exactly what you're going to see. I'll tweet about it, so you'll know that it's out there, but essentially, if you've listened to my talk, you don't have to read this particular issue. So I'm going to share with you 3 cases, and I'm not going to give away the answer at the beginning of the talk. The only way you'll know what the diagnosis is if you remain with me to the end of my talk. So I'm not making this up. This sounds awfully romantic, I know, but this woman was from Casablanca, who presented with bilateral enlargement of her submandibular salivary gland. Notice how symmetrical they are. And gosh, look at that CT scan. They look perfectly identical, right? She also complained of dry mouth, and so she was quite uncomfortable, and that's really what drove her into the hospital. And when you look at this on low power, remember, I'm not going to give you the diagnosis. In fact, I'm showing you 3 cases. Remember, one of them is IgG4 related disease, and the other 2 are mimics of IgG4 related disease. So here it is, and I think to me the most striking thing is this sort of jigsaw puzzle-like appearance. Notice these pieces sort of fitting together. They're large germinal centers as well. Here it is. I always think of, I don't know whether any of you have read the comic Tintin that was very popular in India when I was young. There's a character there called Rostopopoulos, and Rostopopoulos had this really bulbous nose, and every time I see this image, it reminds me of Rostopopoulos. And then within or between the lobules, I see this extensive inflammation and fibrosis. Take my word for it, these are reactive germinal centers, and there's something going on here, but all I'm going to say is that there's an aggregate of inflammatory cells and an arterial channel. And Here's the IgG4 stain. There were increased numbers of IgG4 positive plasma cells, although hold your horses. Increased numbers of IgG4 positive plasma cells does not equate to IgG4 related disease. Well, that's the diagnosis I made at that point of time. I may be right, I may be wrong. All right, so here's another one. This is a man with an oral ulcer, and it looks a little fuzzy, but believe me, there was diffuse inflammation throughout. Lots and lots and lots of plasma cells, some vague aggregates of histiocytes right here. I wouldn't really classify this as a granuloma, but look at the number of IgG4 positive plasma cells, and the IgG4 to IgG ratio was virtually 100%. All right, case 3. Is that IgG4 related disease? Maybe. Case 3 is a 2.5 centimeter pharyngeal mass, and this is the most exquisite storiform type pattern, right? I don't have to explain to you what a storiform type pattern is. And again, look at the tremendous increase in plasma cells. Oh my God, look at the number of IgG4 positive plasma cells, and the ratio is virtually 100%. So the question is, which of these patients have IgG4 related disease, and which of them are mimics, and what are the mimics of IgG4 related disease? So in a nutshell, if you have never heard of this, disease, I'm afraid you've been hibernating for the last 20 years. This is a chronic inflammatory disease, and it frequently forms a mass. It is somewhat like a immune-mediated disease. In fact, it is an immune-mediated disease, but it's a disease like rheumatoid arthritis or lupus. But those diseases typically don't form mass-like lesions, with exceptions. And because it forms a mass-like lesion, it frequently mimics a tumor, often lymphoma. Often it'll land up on the hematopathologist's desk. Well, what is unique to this disease is that it is a multifocal disease and characterized by relapses, remissions, and relapses. So in some ways, when you make this diagnosis, you are making a lifelong disease. And of course, the reason why we get so excited about this is that it responds dramatically to steroids, although it's hard to place patients on long-term steroids. So most of us here are pathologists, perhaps all of us here in this audience are pathologists, and the question you're probably asking me is, how does one make a diagnosis of IgG4-related disease? And my answer to you is it's relatively simple, but as is often the case, the devil is in the details, right? The distinction between, you could argue that the distinction between a malignant and benign process, if you see vascular invasion, you're thinking a malignant process. But then we will argue, is this truly vascular invasion? Is this retraction artifact? And that is what I mean by the devil is in the details. So one, you've got to see a dense lymphoplasmacytic infiltrate, and the critical term there is plasma cells. This is a plasma cell-rich disease. 2, most often you see storiform type fibrosis, and we'll talk a little bit about that. And 3, perhaps the most definitive feature, the diagnostic feature for this disease is obliterative phlebitis. But again, the devil is in the details. So this is storiform type fibrosis. You've probably heard about it in your first year of residency. If you have ever spent time with me at the desk, you'll know that I compare it to a cartwheel. Here's the center of the cartwheel, right? This is right there, the center of the cartwheel. And then you have radiating spokes of fibrosis that emanate from the center. You see them? These fascicles are sort of made up by fibroblasts or myofibroblasts, sort of all running parallelly either this way or that way or that way, creating that storiform type fibrosis. And now I will induct you into the IgG4 Hall of Fame, which is right here in Boston, if you can identify storiform fibrosis in this Van Gogh painting. And indeed, I know I've inducted all of you right now, because right there in the center is the center of the cartwheel, and those are the radiating spokes of fibrosis. But there's something else that is very interesting here, and I'm sure Van Gogh never thought of this when he was painting this. Notice this, that's an arteriole there, and then there are pericentric fibrosis going on around the arteriole. So you look at that, Isn't that all pericentric? Yeah, I know that's the sun. That pattern is actually very classic for eosinophilic angiocentric fibrosis. So here's that vessel, and you can see this perivascular sort of concentric fibrosis. It's a very exquisite pattern. And in fact, these patients with eosinophilic angiocentric fibrosis that you can see in the nose, in the eye, etc., you can have it outside the head and neck as well, show increased numbers of IgG4 positive plasma cells. Here's another patient who had bilateral enlargement of the orbit, and there was all this stuff in the nose. That's about as far as my knowledge of imaging of the head and neck goes. And here you see it again. Pericentric fibrosis, you'll see many fibroblasts, but what is of course very dramatic about this is that there are a large number of eosinophils, something that you can see in IgG4 related disease. Here it is again, and here you see eosinophils to a better effect. So we believe that eosinophilic angiocentric fibrosis, in this paper now almost 13 years ago, boy, I am getting old, we suggested that it belongs to the spectrum of IgG4 related disease. So when you go on higher power, you actually lose that storiform type fibrosis, and you get this sort of basket weave-like appearance that my good friend Tom Smirk, who's now a retired pathologist at the Mayo Clinic, used to talk about, this sort of matted, coir-matted appearance. But when you do go on high power, you'll notice a couple of things. One is that it's always a lot of fibrosis, so it tends to be quite pink and blue, lots of plasma cells. And then look at these cells. These are what I often refer to as the forgotten cells of IgG4-related disease. They're fibroblasts or myofibroblasts. They'll stain with actin. The one thing I would remind you is that these cells should not be showing any atypia whatsoever. Again, the prominence of eosinophils. In fact, the eosinophils can be so prominent that you might actually consider the possibility of a parasite or something like that. Like I said when I started this portion of the talk, the most exquisite characteristic feature of IgG4-related disease is obliterative phlebitis. That said, I think you got to define it very, very strictly. And one of the things that you will notice is that it's sometimes hard to identify these partially or completely obliterated veins in a sea of inflammation. And in general, as a rule of thumb, what helps is that in most organs, including the head and neck, the arteries and the veins tend to run together. So if you see a circumscribed aggregate of inflammatory cells right there, right next to an arterial channel, that is highly suspicious of an obliterated vein. And often the veins have this sort of crescent-shaped lumen, or often the lumen is completely gone. And when the lumen is completely gone, and this was in an orbital example of the disease, you'll just have to take my word for it. This is obliterative phlebitis. And how did I know that? I know that because I did an elastic stain. That's your Hail Mary pass, and I always get an elastic stain when I'm suspecting IgG4-related disease. Anyone who's shown me a case, any of my residents, they'll bring me an elastic stain even before they bring me the slides. That's such a pleasure to get an elastic stain with the case. So here it is. This is obliterative phlebitis. This, of course, was in the pancreas. Here you can see these elastic fibers. You'll have to look really carefully. Sometimes the elastic stain tends to be rather weak. The lumen is completely obliterated. The other thing I'd say is these are just not thrombosed veins. And what I demand to see is that the inflammatory cells in the lumen should look very similar to the inflammatory cells outside the lumen. So not acellular fibrosis that you often see with thrombosed vessels. And you will see thrombosed vessels. Now, to make a diagnosis of IgG4-related disease, you got to have that morphologic appearance, but you also got to demonstrate increased numbers of IgG4 positive plasma cells. And in the ideal world, you should be able to demonstrate increased IgG4 to IgG ratio, although I suspect many of you would not want to count. I have this image here. This is in situ hybridization stains for kappa and lambda, simply to remind me to tell you that this is not a lymphoproliferative disease. This is not a lymphoma. This is a polyclonal process. If you see a monoclonal proliferation, it's not IgG4 related disease. So cheat sheet, we all like cheat sheets. We all like something to carry at the back of our heads. The older you get, the harder it is to remember things. I can barely remember what I had for breakfast this morning. So those histologic features and increased numbers of IgG4 positive plasma cells and the ratio. So we've been seriously studying IgG4 related disease for about 2.5 decades now. And what we realized in the study of this disease, and remember it was originally described in the pancreas, what is now referred to as autoimmune pancreatitis, but we realized that this can affect virtually every organ system, and as of interest to the group here, it affects the thyroid, the lacrimal glands, the nasal cavity, and on and on and on. So just some of the manifestations of the disease in the schematic, or it can affect the sinuses, it can affect the lacrimal gland, the nasal cavity, it can affect the parotid glands, very frequently affects the submandibular gland. There have been actually manifestations described in the larynx, and I could go on and on and on, but I won't. But the one thing we have realized is that in the last 150 years, since we've been seriously studying human disease in a more scientific fashion, is that we've given this disease a variety of names. We now believe that the majority of entities previously classified as one of these entities belongs to the spectrum of IgG4-related disease, and this is only related to the head and neck, or ear, nose, and throat region. I could go on and on about what happens outside this region, but I will not. So let's start with IgG4-related salivaritis, because it's simply one of the most common manifestations you will see under your desk. Rather, on your desk. So in general, IgG4-related disease is a disease of the elderly. But you can see, particularly with IgG4-related salivaritis, you'll see a fair number of younger patients, particularly young women with this disease. Again, in general, while IgG4-related disease is more common in men, it turns out that the head and neck manifestations are just as common in women. In most cases, it is the submandibular salivary glands that are affected. And when they're affected, it's generally bilateral and generally symmetrical. Occasionally, the parotid gland will be also involved. One of the challenges is that the histology of IgG4-related salivaritis is very characteristic in the submandibular salivary gland. Often, it is much more nonspecific in the parotid gland. Another thing to remember is often people will tell you, and this is a sort of a misconception, that all patients of IgG4-related disease have an elevated serum IgG4. That is not true. The sensitivity of the assay, that is serum IgG4, is only about 70%. But more importantly in these cases, particularly with IgG4-related salivaritis, the disease is often confined to, at least initially, to the submandibular salivary glands. And those patients tend to have a relatively normal IgG4, serum IgG4, or it could be entirely normal. To my eye, the histological features of IgG4-related salivaritis involving the submandibular salivary gland is very, very characteristic. So I'm willing to go out on a limb and call it IgG4-related salivaritis even without the IgG4 stain. And you'll immediately notice that I am diminishing the need or the value of a tissue IgG4 stain, something that I will talk about a lot more as we go along. So this is IgG4-related disease of the submandibular salivary gland, and the first thing I want you to notice is the lobular nature of the lesion. So that tells me many things. One, it could be IgG4-related disease, and two, it's benign. I mean, in general, anything lobular is benign. So just to trace out for you, here's a lobule, and they sort of fit into one another like a jigsaw puzzle appearance. So that low power appearance is very helpful. There's several things here on this image that are very telling for IgG4 related disease. Yes, the lobular pattern, but also notice the interlobular expansion, the massive inflammation. These are deeply inflamed, so much so that you would consider a lymphoma. There's a couple of other things. Notice there are ducts here, but there's no ductal damage and there's no periductal inflammation. In fact, the inflammation tends to stay away from the ducts. And finally, there's something going on here that we'll talk about in a minute. So now we're in between the lobules, and this is what I refer to as cellular fibrosis. So in many cases, you may not see that classic storiform type fibrosis, but you will see this very cellular inflammation. To me, to my eye, this tastes and smells of IgG4 related disease. The moment I see this inflamed stroma, these fibroblasts or myofibroblasts, these plasma cells, and hopefully a couple of eosinophils here and there, that sucks me into the diagnosis of IgG4 related disease. And finally, it is this is the sine qua non to my eye of IgG4 related disease, obliterative phlebitis. Now, you'd say it's so easy to miss this, right? But remember, arteries follow veins. Any circumscribed aggregate of inflammatory cells in something you're suspecting IgG4 related disease is likely obliterative phlebitis. There's a sliver of a lumen there. Again, I'll point out to you that the ductal epithelium is perfectly preserved. Here it is on higher power, and there's a sprinkling of eosinophils here as well. So here's a question for you. What is the most common entity that is misdiagnosed as IgG4 related salivaritis? I promise you, you've probably done it, and I can tell you that I've done it as well. And here are the reasons why that happens. But first, what are the difference between chronic salivaritis and IgG4 related salivaritis? It is by far and away the most common mimic. And I think the key is, one, it tends to be less inflamed, but what is less to you is maybe more to me, etc., etc. Look in the interlobular stroma. It looks acellular. And what is missing are the inflammatory cells, and that is not the case. Remember, the classic features of IgG4-related disease is that inflamed stroma. Here's why chronic salivaritis, not otherwise specified, is commonly mistaken for IgG4-related disease. You may see a increase, not only an increase, a diffuse increase, an increase to the levels that mimic IgG4-related salivaritis. So again, de-emphasizing the value of a tissue IgG4 stain. So here's your cheat sheet comparing the two diseases. IgG4-related salivaritis is characterized by cellular stroma, obliterative phlebitis, these very large, geographic, irregular germinal centers, typically no stones. There could be an overlap in the number of IgG4 positive plasma cells, and the reason why we make so much fuss and we talk so much about it is even a short course of steroids is sufficient to get rid of this bilateral submandibular gland swelling. So, if there's nothing you remember from what I just said, compare these two. Cellular stroma, acellular stroma. That's it. So I told you that the submandibular salivary gland is the most commonly involved, but the gland can infect multiple glands as well. And here's a patient, and we have his consent to do this, who was the prototype of multi-gland involvement, what is we would refer to today as this patient has IgG4-related disease. Notice this: bilateral lacrimal gland disease, bilateral parotid gland disease, bilateral submandibular glands, and I can tell you that there were sublingual glands as well. This is what people used to refer to as Mikulitz's disease. Now, if you've never heard of Mikulitz, don't bother. I wouldn't start now. And this man had been, interestingly, roaming around the corridors of Mass General Hospital forever and ever, searching for a diagnosis, and, with that facial expression. Looks pretty good, though. With that facial expression, I would be concerned as well. And when we look at this, there are large germinal centers. I can promise you there's some fibrosis, but there was neither obliterative phlebitis nor classic storiform type fibrosis. And like I told you, those manifestations you see in the submandibular salivary gland, for whatever reason, you tend not to see in the parotid. But look at the IgG4 to IgG ratio. It took us forever to get these blocks from the outside institution. It's a massive increase, but The ratio is also almost 1:1, but I think the most telling feature on this patient was the massive serum IgG4. Sort of allows me to make another point about the diagnosis of IgG4-related disease. Histology is great, but it's seldom considered the gold standard. You've got to put all of the pieces together, and in this case, classic involvement of these glands in the face and the neck, increased numbers of IgG4 positive plasma cells, a massive increase in serum IgG4. That's an eye-popping level. When you see a level like that, it's either IgG4 related disease or it's lymphoma. It can't be anything else. And these plasma cells were indeed polyclonal. So this is not a diagnosis to be made in the isolation of your office. This is something to be made together with your clinician, with your radiologist, with your rheumatologist, or whoever the treating physician is. So why all this fuss? Look at this appearance. This was 2 months up before rituximab, and look at this after 2 months after rituximab. And our group was the first to report that rituximab is a very powerful, relatively non-toxic way of treating this disease. So a dramatic effect. Here's another case from, I believe this was from Bolivia, and this woman not only had evidence of Miculitz's disease, but also had a massively enlarged pancreas with obstructive jaundice. And in this case, we actually made a biopsy on a lip biopsy. Now, there's some fibrosis here, but none of those classic features of IgG4 positive cells. Massive increase in tissue IgG4 as well as a ratio. And what is unique about this case? Let me step back for a second. What is interesting about the way one makes this diagnosis in this case is histology was only one part of that big puzzle, right? The bigger parts of that puzzle were that classic clinical appearance and the increased number of IgG4 positive plasma cells. Any one of those features in and of themselves are not necessarily diagnosis. You have to take this global view into account when making the diagnosis, and this is where people really get into trouble when they rely solely on histology. All right, so let's talk about what is not IgG4-related disease. And as I said, this is probably the most important part of the talk. So if you've been sleeping all along, time to wake up. So here's I think this was a parotid. You look at the interlobular stroma, and there is actually not a lot of that cellular fibrosis. But there is massive inflammation, these very large geographic germinal centers. And there are these lymphoepithelial lesions, right? This is not IgG4-related disease. This is lymphoepithelial salivaritis. And if you go staining this for IgG4, you'll typically see almost no IgG4 positive plasma cells. So that's sort of very reassuring. So with IgG4-related disease, you do not see lymphoepithelial salivaritis, although, when you see something like this, you must consider a lymphoma, and then your hematopathologist becomes your closest friend. Here's another parotid mass, and now I'm looking at storiform type fibrosis, right? So here's the center, here are the spokes. Pathology is, as I say to some of my residents, is the art of the imagination, right? You gotta have some imagination, and if you imagine just right, you will see the storiform type fibrosis. There was a substantial increase in IgG4 positive plasma cells. I am not a Bond counter, but I counted about 100 per high power field. But, you might be thinking IgG4-related disease. This is not IgG4-related disease for several reasons. One is there are multinucleate giant cells, and they have these small granulomas, neither of which you should be seeing in IgG4-related disease. Here are they again, small granulomas. Interestingly enough, there was no necrosis, and there was some sort of a lymphocytic vasculitis. This is Wegener's granulomatosis, and this is sort of the kind of Wegener's granulomatosis you are used to seeing. And I'll tell you one thing, that you tend to see more IgG4 positive plasma cells in Wegener's granulomatosis than you see in IgG4-related disease, and hence they are often mistaken for one another. ANCA is a positive ANCA. It should be negative in IgG4-related disease and positive in Wegener's. So Wegener's, the new term for Wegener's is granulomatosis and polyangiitis, or GPA. So forgive me if I'm using archaic terms. But the one thing I've realized over the years, and my interest there has really been piqued by my interest in IgG4 related disease, and therefore I've been seeing all of these other inflammatory diseases, is these forms of Wegener's granulomatosis. I can tell you this nasal lesion was the Wegener's granulomatosis. The kind of Wegener's granulomatosis we see now, and I've been trying to write a paper about this, it's never got to it. The kind of Wegener's granulomatosis we see now is not your grandfather's Wegener's granulomatosis, right? Your grandfather's Wegener's granulomatosis is granulomas, necrosis, multinucleate giant cells, etc., etc. But you tend to not see that here. You just see this inflammation, lots of plasma cells, eosinophils, and the pitfall always is that there is a significant increase in IgG4 positive plasma cells, although in this case the ratio isn't that high. So both these cases of Wegener's granulomatosis, and like I said, you tend not to see this classic triad. So I think before you make a diagnosis of IgG4 related disease of head and neck, one, consider Wegener's granulomatosis, and two, Wegener's granulomatosis can show a substantial increase in IgG4 positive plasma cells, again de emphasizing the importance of the IgG4 stain. Okay, so just moving on to the thyroid a little bit. This was the prototypic case. This was a case of Rydell's thyroiditis. This was a youngish woman. Anyone less than my age is young. I'm sorry, my definition just keeps moving. It's a moving target. She had this very hard, woody mass, and you can see she's had a biopsy not so long ago. And this was the index case and we reported a series of cases of Rydell's thyroiditis. There've been other series now. Here's the CT scan. Here's the big mass in the thyroid. It was very hard. And the classic features for Rydell's thyroiditis that other forms of thyroiditis don't do is the infiltration of the skeletal muscle. Look at it, just marching its way through the adjacent strap muscles. I think that's what they call them, right? And then the increase in IgG4 positive plasma cells. So this is a thyroid. This is something that is often confused with Rydell's thyroiditis. And so I'm going to play a short video for you, which is going to demonstrate this entity, which is referred to as the fibrosing variant of Hashimoto's thyroiditis.
So I wanted to share this case with you. No mystery, this is the fibrosing variant of Hashimoto's thyroiditis. And I've been fascinated by this entity for two reasons. One, of course, of its association or reported association with IgG4 related disease. And then, of course, this paper, I believe in the 70s, from Austin Vickery from Mass General Hospital, who talked about this entity. Thyroid follicles surrounded by an ocean of plasma cells. So virtually every cell here is a plasma cells other than a few scattered lymphocytes. And regardless of where you go, this is the morphology you'll see. This time around here are the thyroid follicles, small brown microfollicles, intense fibrosis, and a bazillion plasma cells. You back out and this is what you see. Interestingly enough, unlike Rydell's thyroiditis, the fibrosis, although it extends into the capsule, does not extend into the neck and the muscles of the neck. Here's another look, again, that very lobulated profile, a few germinal centers, not too many. And this is what you see with classic fibrosing variant of Hashimoto's thyroiditis. At times, it's very hard to even identify the underlying thyroid follicles, because the inflammation just drives everything out. So the reason why we got excited about this entity initially was because of a tremendous increase in IgG4 positive plasma cells. And as you can see, this IgG4 stain, a substantial number of cells are actually positive for IgG4. And this gives it this very diffuse and dense appearance. This is way more than you even see with IgG4 related disease. That said, take a look at the IgG4 to IgG ratio. Well, granted, there's a large number of IgG4 positive cells, but this ratio was under 30%. And that's an even more high power, showing that relatively low ratio. So all of that is pretty typical for a fibrosing variant of Hashimoto's thyroiditis. Dense inflammation, intricately woven in fibrosis, elevated IgG4 cells, slightly elevated but not perfectly elevated IgG4 to IgG ratio. But the broader question is this entity related to IgG4 related disease? And the more specific question is, will this patient go on to develop systemic IgG4 related disease?
So the answer to that question, albeit with my implicit bias, is that I do not believe that this entity belongs to the spectrum of IgG4 related disease. And I say that for two reasons. One is I've never seen this disease associated with IgG4 related disease, and I've never seen a patient with this morphology and immunohistochemical profile progress to IgG4 related disease. Nevertheless, I hope you'll agree with me that it is a very unique morphological appearance that differs from Riedel thyroiditis, which is an IgG4 related disease on one hand, and Hashimoto's thyroiditis, which is a completely different morphological appearance, a very, very pretty entity, fibrosing variant of Hashimoto's thyroiditis. So here's what I think is happening, and as I said, there are other points of view. So, in my mind, there is no question that Riedel thyroiditis belongs to the spectrum of IgG4 related disease. I'm increasingly skeptical about the fact that fibrosing variant of Hashimoto's thyroiditis belongs to the spectrum of IgG4 related disease. By the way, that paper, to put a plug in for my journal, that paper was published in the Journal of Clinical Pathology, and I'm absolutely certain that Hashimoto's thyroiditis does not belong to the spectrum of IgG4 related disease, although you'll find some cases of Hashimoto's thyroiditis with increased IgG4 positive cells, and they behave in a somewhat different fashion, in a somewhat, if you allow me to use the word rather loosely, in an aggressive fashion. So here's the question for you. You get this, you walk in on a Monday morning and somebody asks you, oh, God forbid, on a Friday evening, can you stain this for IgG4? And really, it has very little value unless you're thinking of Riedel's thyroiditis. So you're within your rights to tell him or her that, look, this is not going to help you one way or the other. That said, when people ask me to stain for IgG4, I almost never say no, but I add that note in that the clinical significance is totally uncertain. All right, so, this is the very end of my talk, and as I promised you, I'm going to give you the answers to those three cases, if you remember. I hope you do. There were three cases in all. One of these cases was IgG4 related disease, and the other two were not. And to start one, let's start with this young woman from Casablanca. That still sounds so romantic to me. Bilateral symmetrical enlargement of her submandibular salivary gland. Notice how symmetrical they are. And I can tell you that she also complained of dry mouth. And here's the low power picture, and I'll tell you right off the bat, this is IgG4 related salivaritis. It is so classical, just a low power appearance is sufficient for me. I mean, I certainly don't mean to brag, but it is so very typical. I love that low power. And what you're looking for is really this jigsaw puzzle-like appearance. Look at the way these little units, these inflamed lobular units, fit into one another like a jigsaw puzzle, banded into lobular stroma. Notice those large reactive germinal centers. This is Rostopopulus, this time in an inverted fashion. Very typical for IgG4 related salivaritis. Storiform type fibrosis. Here's the center of the cartwheel, and here are the radiating spokes. Notice this very cellular stroma, all typical. Do you see the obliterative phlebitis? If you haven't seen it, it's right here. Remember the mantra, you follow the artery, you'll find and you find a circumscribed aggregate of inflammatory cells next to an artery that has an obliterated vein. And if all else fails, you can always use an elastic stain. And there's the IgG4 stain. There was a diffuse increase in IgG4 positive cells. And here's another thing I'll tell you. It's the diffuseness of the inflammation that is helpful. Focal pockets just don't do it for me. So this was classic IgG4 related disease. This second case, this is not IgG4 related disease, is a slightly older man who's not been up to any good, had this diffuse plasma cell infiltration, lots of plasma cells, vague granulomas, massive increase in IgG4 positive plasma cells, and you're thinking this has got to be IgG4 related disease, and it is not, because this is the immunohistochemical stain for syphilis, and you can see those organisms crawling all over the place. Naughty, naughty man. So I think before you make a diagnosis of IgG4 related disease, think syphilis. And both in the aerodigestive tract, but also in lymph nodes. And that's a paper that we wrote not so long ago. Oh, it's now 5 years. It was led, the last author was Lauren Zuckerberg, a great friend of mine who passed away on Christmas Day last year. Lastly, a 10-year-old male with a 2.5 centimeter pharyngeal mass, and you're looking to yourself and saying, oh, isn't this classic storiform type fibrosis? Here's the center of that cartwheel. Those are the radiating spokes of fibrosis. Lots of plasma cells, but what I sort of didn't focus on when I showed you this case initially was these large vesicular cells. Now, you might say they're not atypical. To my eye, they are very atypical. This is not something that you will see in IgG4 related disease. And even though there was a massive increase in IgG4 positive plasma cells, those atypical cells were positive for ALK. In fact, this had this ALK fusion, and this is an inflammatory myofibroblastic tumor, and we had a paper about this not so long ago, which showed that there is an overlap between the two entities, and the two entities being IgG4-related disease and inflammatory myofibroblastic tumor. And so I'm consciously thinking of IMT before I make a diagnosis of. All right, so some parting words of wisdom. Here we go.